So thank you very much for coming to it's the first one of 2026. Street Vet Skill Set Monthly CPD. This is being recorded as usual so that we can share it on the volunteer portal for people to get their CPD. Welcome to friend of Street Vet. You've been on the board for, I don't even know, since I started it, I think. He's our internal
Long
medic
time.
on the Street Vet Specialist Advisory Board, and I've roped him into helping us create an SOP for antibiotic stewardship for street vets. So we will hopefully be unveiling it, makes it sound really grand, before the February CPD so people can have a look at it, because the aim of the next CPD is for us to, yeah, just really it's a Q&A, it's a chance to talk and get your guys' feedback and thoughts on the changes that we're going to be making. But before we have that, we thought it would, well, Ian thought it'd be a good idea because I struggle. I think things have changed quite a lot in interpreting profiles and culture and sensitivity. So he said he would do some CPD on it. So I'll stop talking and hand over to Ian, and I'm pretty sure he will be more than happy to be interrupted and asked a question. But if you otherwise want to wait, we will do questions at the end. So if you want to keep your camera on, amazing. If you don't, I might end up eating because I just might. So I will put my camera off at that point. Ian, thank you so much.
No,
Over
thank
to
you,
you.
Jane. Thank you. And absolutely. If I, I'd sooner you interrupt me and me go through something again than me wait till the end of the talk, because we want to make sure everybody understands all the different parts. So we're going to talk about interpreting those culture and sensitivity profiles, that'll hopefully allow us to optimally choose the right antibiotic. And there's going to be two parts to the talk, if I can move my slides. So first of all, we are going to talk a little bit about what the actual numbers are on what they mean, how they're developed, and what's the science behind developing these MICs and these breakpoints. Because I think that's really important to then understanding, you know, the kind of algorithm of ch making a choice of the drug that you're going to use in these situations. So this is a kind of typical kind of culture and sensitivity report. This is actually one from an American lab, so it's a little bit unusual. In the UK, we don't include drug dosages, but they do in the States in some of the labs. And we've got the familiar. We all look at the S's. There's a lot down here, and this is an E. coli that's got a lot of sensitive to a lot of bugs, and then we've got these intermediate drugs here, intermediate sensitivity drugs here, and we're going to talk a little bit about what all that means later on. But first of all, we're just going to refresh, what this is here, the MIC. So the MIC, otherwise known as the minimum inhibitory concentration, is the concentration of drug in micrograms per mil that will inhibit this bug that's been cultured from the sample that you submit. So it's very specific, that drug to that specific concentration. And I'm sure this is sending you all back to your undergrad microbiology, familiarity with these are micro broth chambers, where essentially you have a series of drugs in here they're labeled A, B, C, D, E, F, and then you inoculate the bacteria that you've cultured in one side of the chamber, and then there's increasing concentrations of the drug as we move horizontally across the broth chamber. And wherever the bug stops growing, that's essentially your MIC. So that's pretty straightforward. Now, for some reason they've called them adult reference ranges on this USA report, but essentially we call them breakpoints. So what are the breakpoints and how are they generated? Because these breakpoints are really important because we need to compare the MIC against this breakpoint range. So normally they've got a lower range. This has got 4 to 16. So anything with an MIC that's between 4 and 16 will be termed intermediate. And then above 16, that's then considered resistant. So how do we come up with those values? So it's actually quite a really complicated process that if I'm being honest, I've sat in microbiology lectures recently and I understand half of what they talk about. And then as soon as I leave the lecture theatre, I forget quite a lot of it because it's quite complicated science and statistics. But essentially, the key points that we need to remember on how a breakpoint is generated is that there's a number of different factors that feed into it. So the first is the individual drug. The individual drug has pharmacokinetics. So that's how it's metabolized and what concentrations it will reach in the serum. And that's going to be affected by the species of animal, but also the dose that you use. So breakpoints are generated based on a specific dose regime in a certain species. So 10 mg per kg in of an antibiotic in a dog will reach a certain amount of concentration in the serum of a dog. 10 mg per kg in a cat will potentially reach a different level in the serum because it's got different physiology. Likewise with a human or a horse. So the first thing that goes into these breakpoints is they have to work out how the pharmacokinetics of the drugs influence is what can be achieved in the serum of that individual species. They then have mechanisms of looking for novel resistance mechanisms based on microbiology. And in human medicine, they also have a much better surveillance, so they can look at outcome measures from clinical data based on treatment successes of the culture and sensitivity reports that they're putting out. So there's a huge amount of information that's really complex, and they use a lot of stats to kind of work out different thresholds. And essentially, they come up with this kind of profile. And this is from UCAS, which I'll mention in a moment. But essentially, what they're aiming to do is essentially make a cutoff, which they call ECOF, which stands for epidemiological cutoff value, so that 90% of the bacteria that they test against this drug will be inhibited by it. So, when you have a sensitivity profile that says it's, that the bug is sensitive to that antibiotic, it's 90% of that population of that bacteria should be sensitive to it. And then we have this intermediate range where, if the drug's pharmacokinetics can, because these are often tested against blood levels, but if you've got an area of the body where the drug might achieve higher levels, then this drug may be effective, and then we've got resistance. That's where it's this bug can tolerate drug levels higher than what you can achieve in the serum. So when we come back to this sensitivity profile, essentially what I've already what I guess I've already explained is that the E. coli is tested on in a broth against all of these drugs. And essentially, where it starts to not grow is where the MIC cutoff is. And then to get your sensitivity or intermediate or resistance, this value is compared against the breakpoints. Now, what I hope you realize now from what I've just explained is that these breakpoints are very specific to a species, a drug dose. So they can't be compared in any other way. And I've certainly come across vets that, understandably, it can get confusing, may look at the MICs and actually say, well, this one's one of the lowest ones, 0.5, so I'll go for this one. You can't compare these MICs against different drugs because they're all based on different drug dosages and different breakpoints. The only way that you can compare the MIC is against the individual breakpoint relating to that drug bug combination. Okay. Hopefully that makes sense. Now, in modern laboratories, I mean, I guess when I graduated many moons ago, most laboratories were still using disk diffusion, and then there's little strips as well. But gradually, with modern technology evolutions, labs are now processing huge amounts of culture and sensitivity profiles using micro BOFs, similar to the MIC chart that we showed before. and they're running them through these automated machines, and they can, they can I mean, some of the labs in the States are processing thousands a day, which is quite staggering. Um, there are, some of the technology that you may hear microbiologists talk about. There's this one called MALDI-TOF, which I think stands for, if I remember correctly, matrix. It's matrix associated laser, and I can't remember the second part. But essentially, this is a way of identifying bacteria just molecularly, looking for markers on the surface of their bacteria. So it allows them to more accurately diagnose, more accurately and quicker to diagnose, to identify which bacteria is in the culture plate. So really fascinating technology. You may also come across, and this is a bit of a heads up because labs are trying to, it's almost like when you find a technology, you want to find a use for it. So now some of the labs are looking at using PCR to identify resistance genes in bacteria, which all sounds very exciting because again, that could be done very, very quickly. You imagine you get your bug, you identify it, you do a PCR on it, and you can say there's a resistance gene for N-rofloxacin, amoxicillin in this bug. The difficulty is the presence of the genes doesn't mean that they will be phenotypically expressed. So you can get this really confusing situation where your sensitivity profiles say it's sensitive for, say, on rofloxacin, but the bug will have the resistance gene. So at the moment, some of the labs are debating putting that out. If they do, my personal recommendation at the moment, because we don't fully understand how to use it, it's best to just stay with the what we know until knowledge of how to interpret those genes actually is better understood. Now, I've talked a little. I appreciate I'm labouring the point about the breakpoints a little bit, and now hopefully, the next part of the talk will emphasise why I've done that at this current time. So there's two large organisations that set those breakpoints. The voluntary organisations. There's about 30 to 50 microbiologists who all sit in a room and debate all the data. There's the Clinical Laboratory Standards Institute, the CLSI, that's based in the States, and then there's the UCAS, which is based in Europe, hence the title. Now, one of the challenges we have is that because of a lack of pharmacokinetics data that's reliable for a number of veterinary species and a veterinary bug drug combinations, there aren't breakpoints available. So a lot of labs up till now have had to rely on human breakpoints, which obviously aren't going to be as accurate as as if it was generated for a specific animal, say a dog or a cat. And some labs take a slightly different approach. Sometimes you might use a human breakpoint, or if it's developing a breakpoint for a cat, you might use a dog breakpoint if it's available, hoping that the pharmacokinetics are similar. So there are unfortunately compromises in some of this technology and some of these testings that we're able to do.
Can I ask a question?
Yeah,
Sorry.
yeah,
I
yeah.
was trying to work out how to raise my hand and I couldn't find it. The Zoom has changed. You can chime now to raise your hand. What's
Oh,
that about? Didn't want
interesting.
to do that.
Yeah,
You know what you were saying a minute ago about the MIC and the breakpoint and the fact that in America they were giving specific dose rates.
yeah.
Surely, like, you kind of need to know that, right? In order to make an informed decision. So in terms of like, I don't know, some people use 5 mg per kg as opposed to, whatever of Zodon antirope. So
Yeah.
why don't they do that in the UK?
Well, I guess they're trying to keep it separate from because I guess because I've had discussions with the labs in the States because it creates it 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 it, it, it kind of some of the vets were falling into the habit of just going, oh, it's sensitive. I'll look at that. That's the drug dose I need to use, and then that's it. That's all they think about. So it kind of
Hmm.
tunnel visions them. The lab reports that some of the lab reports I've seen in the UK, they'll often have links to the CLSI guidelines that you're using, and you can see the dose rate. Most of the situations, the BSAVA formula aligns with those dosages, so you're fine.
Okay.
But yeah, it's actually in one hand, you think that's a very sensible thing to do because it's making sure that people are using the right drug dose. However, it kind of you can see habits that have developed in the States where people aren't even they're just going, oh, boom, boom, thinking, not even, they're just thinking that's the drug I have to use at that dose and not really putting much more thought into it. So they're trying to remove it just to try and, get people to think more progressively and holistically about the cases. So, good question though, because when I first saw it, I thought that makes sense. So, the reason why I've been mentioning the CLI and the breakpoints is that these breakpoints are reviewed every 3 to 4 years. And there was a big review from CLSI in 2024, which, due to increasing knowledge of pharmacokinetics, was able to make a number of changes. And it's probably the most changes that have been made in veterinary breakpoints for some time. This process will be repeated in about 3 or 4 years' time. Whether they'll be able to make the same number of changes, we don't know. It's pretty early in the data, but some of these changes were quite significant, and you may start to see some of these tinker through into your lab reports. So a positive is that, because of increasing knowledge of pharmacokinetics, some drug bug combinations now had veterinary specific breakpoints, which is great. So the human breakpoints could be replaced with a veterinary one. One of the downsides of this situation is that there was a lot of changes. So, for the labs, when you consider all the automation that they use, it takes a long time to adjust all those machines. With one lab in America, I had some time with, it was taking 6 months just to redesign all the plates to go into the machine, let alone the other parts of the process. For a number of drugs, the breakpoints had been lowered. This means that in a number of situations, bugs which we previously thought were being sensitive, that were sensitive at certain drug dosages, are now going to be reported as resistant. An exciting change, if you're a bit of an antibiotic geek like myself, is that breakpoints up till now have always been designed on serum or plasma levels. But we know that the pharmacokinetics of some drugs, such as beta-lactams, that they have different pharmacokinetics, so they can reach much higher levels in the urine than in the blood. So they've now created breakpoints for different body systems when possible, which is good. And a further new evolution is that with some drugs, they've introduced what they're terming susceptibility dose dependency. So this is primarily with the fluoroquinolones, where they're assessing resistance at different drug dosages. So if you think about the pharmacokinetics, what level of drug will be able to be achieved in the serum, they're looking at whether the bugs are still sensitive or resistant at 5, 10, or even 20 mg per kg. So this is one of the examples, just to show you how they've changed and lowered some of the breakpoints. So the sixth edition is the edition from 2020. So with an E. coli or an Enterobacteriaceae compared against enrofloxacin. So remember, we've got to always have that drug and bug combination very specific. You can see in the sixth edition, susceptibility was deemed anything less than 0.5. Whereas in the seventh edition, they've now deemed anything above 0.5 as resistant or equal to 0.5. So there's been a real shift in that breakpoint. Now we've got this kind of lowering of the breakpoint, but also at different dosages. So when using enrofloxacin at 20 mg per kg, susceptibility is deemed less than 0.25 mg per kg in the well, and 10 mg per kg. There's a slightly lower kind of breakpoint again. Sorry, I've kind of been a bit waffly on that one, but essentially, it's just a good example of how they've had to reduce the breakpoints based on new data, which means that some of the bugs that we previously thought were sensitive are going to be reported as resistant. considering the urinary tract specific, as I mentioned before, the beta lactams, we know that these drugs can reach higher concentrations than in the serum. So as a consequence, they've created urine specific breakpoints. Which is great because previously we would be trying to make decisions for urine based off predictions for how the drug would perform in the blood. And so, what you might start to see, well, you should hopefully start to see on your lab report soon is urine specific breakpoints. And as you can see in this E. coli amoxicillin combination, um, when you're considering the lower urinary tract, a bug can be seen as susceptible up to 8 micrograms per mil, whereas when you're considering the serum, anything above 1 micrograms per mil is considered resistance, and that reflects the fact that the drug can reach much higher concentrations in the urine, and therefore that higher concentration can overwhelm the resistant mechanisms that the bug has. One of the challenges that we'll need to communicate about this is that urine levels are only going to be are going to be applicable to lower urinary tract infections because that's where the urine concentration will be maximum. If you're treating a case of pyelonephritis, the urine tract breakpoints aren't going to be relevant. In fact, you need to rely on the systemic because you're essentially treating that with serum concentrations of that medication. So hopefully I haven't lost you all with all those numbers. But what this essentially means for clinicians is that, although some of the breakpoints have reduced and we are going to see more resistance on some of the reports, the changes are important because this means that when we make a choice of the antibiotic we want to use based on the sensitivity report, it's going to be more accurate, so we'll get better outcomes. I've already hinted at it, but the challenge is there are so many changes. There are there are about 50 changes without this document which are relevant to veterinary species. The labs are, essentially working really hard to try and catch up on this and try and re-evaluate their systems. I know in the States there was one laboratory that took 18 months to get everything lined up. But what I would say is it would be worth asking your lab to see if they are aligning with the new CLSI guidelines. Because I've certainly come across some labs, and not naming any names, but they are, when I've pressed it and chatted to them, they've been using breakpoints that are sometimes 10, 12 years old and haven't been following the updated guidance. So with that and that horrific chat about breakpoints and all the science behind it, we'll now get to the more clinically relevant bit, which is essentially if you've got a culture and sensitivity profile in front of you, how are you going to approach it, how you're going to interpret it, and how you're going to make a good drug choice.
Can I ask another question?
Go for it.
This is me with I've got my dinner on my lap, which is why I've
Right.
put the video off.
What dinner? Nice
When
dinner.
do they have a time frame with which they have to comply by?
Nope, it's not. It's not compulsory. So,
Wow.
not all labs have to. There's not that I'm aware of, unless it's a government lab. I don't think there's any regulatory framework to say that they have to show what kind of quality assessments they're doing. So,
Right.
I don't believe that there's any framework where they have to sign up and say that they're definitely changing to the CLSI guidelines. If you ask, and they're not doing it, that's a way of kind of putting that pressure on it, really.
Okay. Thanks.
Yeah. I
Because
do
we use like three different labs at Street Vet. So.
Yeah, I do know some labs that have definitely done it, but I'd feel a bit uncomfortable because that would be
No, no, I'm not asking. It's just I'm just thinking we have three different ones, so it means
or we can maybe, yeah,
I can ask.
because if I name the ones that I know definitely have, it might be the other ones also have, but I just don't know. So I don't
Yeah.
know.
No, no, that's fair. Thank you.
Cool. But also good question. So we so where are we? Okay, yeah. So we've got our sensitivity profile in front of us, and we're wondering what to do with it. And the absolute first question that you should be asking is, do I even need to treat this bug? So obviously, you know, it could be a contaminant. When we think about that most with urinary samples, if we're not taking them as by cystocentesis, if it's free catch or via a catheter, but you can get contaminants in other situations. And the most important thing really to consider is, would I expect this particular bacteria at this site that I've taken the sample from? And if it's not, then maybe it's a contaminant and doesn't need to be treated. Is this bug clinically relevant? So um, the example I'm going to use here is again the urine. So for a long, long time, and I can confess that this was part of my lectures for a number of years, and it was just a reflection of how medical knowledge evolves and how our understanding changes. So I would talk about, doing urine samples in Cushingoid dogs and things like that, and getting positive urine culture results that we thought were important to treat. And we used to talk about how the Cushing's might be suppressing the inflammatory response. Well, there's a lot of evidence now in the human sector that, we've assumed for a long time that our bodies are sterile in certain parts, so the respiratory tract, the bladder, but actually it's pretty normal to have transient bacterial loads in those organs without causing a clinical uh, problem. And asymptomatic bacteria, so the presence of bacteria in urine without any accompanying clinical signs, is well recognized in humans. And in some situations, you may even also get pyuria, so presence of white blood cells in the urine. And in that situation, unless there's clinical signs and feel that you've got a clinical diagnosis where there's an active infection, in a lot of cases, it's not treated, and the bacteriuria self-resolves. Now, this is a very a little screenshot of the ISCAID guidelines from, I think, about 2019 as well. I know that these are being redrafted at the moment. And within that text, it does highlight there's a couple of studies, one with, I think, about 90 dogs or 100 dogs that had their urine tracked for about 3 or 4 months, and about 10% of those dogs had bacteria cultured from their urine, but showed no clinical signs, and the bacteria cleared without any treatment. So again, this would align with asymptomatic bacteria that's seen in humans. And similarly, they had a study of about 70 cats where, again, they followed, and about 10% of the cats had bacteria that didn't affect survival, it didn't cause any clinical signs, and again, self-resolved. And this has been a real game changer in human medicine for antibiotic use, because there was certainly an over-reliance of antibiotics in these cultures, and getting these cultures that were taken as standard, and over-interpretation and over-prescribing. So, in people that have got urinary catheters indwelling at home, they'll if they identify bacteria, they'll simply just change the catheter rather than treat it. There are scenarios like, for example, if people's had a renal transplant previously, they would have gone straight in with antibiotics, but now they just monitor if there's no clinical signs, because they know if they overuse the antibiotics, they're going to potentially select for a resistant bug eventually, and then that will be really catastrophic. The other thought to have as well, when we're coming back to our questions about whether we need to actually treat this bug, is, has the patient got better on my prescribed treatment? And sometimes we can get the culture report, see there's a bug, see it's resistant, and forget to look at the patient and realize actually that the wound has healed. And if it's healed, the immune system's done its job. So in those situations, we don't need to treat. So just as a quick example to kind of mix up the algorithm a little bit, this is Biscuit, who's a young female neutered dog that's got a hot spot on the right antebrachium. And somebody else in the practice will say your boss took a swab and prescribed some treatment. They didn't even write down very well what it was. And the notes are pretty suboptimal. And the owner's called 3 times about the results, so desperate to hear. And you've got this sensitivity and culture profile, And immediately your eyes are drawn to all these R's and the concern that this drug, this bug is a resistant bug, and this is going to be a tricky one to manage. However, if we just take our step back and think about, do we, first of all, do we need to treat this bug? Well, if we look at the bacteria that's been cultured, it's a methicillin coagulase negative staph. So we only associate skin pathology with coagulase positive staphylococcus. So as it's a staph negative, it's probably not relevant because it's not pathogenic. It doesn't need treating. We haven't spoke to the owner to see whether the treatment prescribed by the your boss has actually worked, because if it has, we don't need to worry about the results now because it's all resolved. And then the last point to mention, and we'll touch on it a little bit more, but I thought it's relevant to bring it up now, is that when we talked about how these breakpoints are generated, I emphasized that in the majority of cases, they're all based on breakpoints of drug concentrations in the blood, in the serum. And there's now those new ones talking about breakpoints in the urine. But this is topical, this is on the skin. So what if we can use a topical product, any medication topically that we use will reach much higher concentrations than what can be assessed in a breakpoint, in the standard culture and sensitivity. So even if I did think this bug needed treating, if I'm going to use topical treatment, these breakpoints aren't relevant, to a point where, for anything topical, you're going to reach much higher concentrations. And that's similar, the same lesson for ears as well. There's very limited value of doing a culture and sensitivity profile from an ear. Absolutely do some cytology to identify whether it's cocci or rods. If it's finding it very difficult to treat, you might want to do a culture to see if it's Pseudomonas and identify it. But the sensitivity profiles that you're going to get for those bacteria, if you're going to use topical medication, they're not really going to be influencing your drug choice. So coming back to this kind of, do I need to treat the patient when it's got better? This is a really nice example, from it's not the actual photo, but it's a reminder of a case that was managed by my colleague Ronan Doyle when we worked together at Davies. So this Siberian Husky came in and it had the most horrific anal abscess that had ruptured and essentially gone all the way into the gluteals. And um, it was a surgical situation requiring necrotic tissue to be debrided. Drains were placed and the tissues were brought back together. And amoxiclav was started perioperatively because obviously it was an infected site. So they wanted to be proactive and start to treat as soon as possible. And this is the culture profile that they received a few days later. The dog was hospitalized because it needed a lot of drain management. And as you can imagine, Ronan came and found me because he was a little bit concerned because he cultured 3 bacteria. We got Pseudomonas, E. coli, and Enterococcus. And as you can see, we've got a lot of resistance. And Ronan was concerned because essentially there was only one antibiotic that could treat all 3 bugs unless we were going to start using polypharmacy. And then it was going to get a little bit more complicated. So my view of this is, I guess, similarly to the example with the coag negative staph, is that Enterococcus, that's a bystander in this situation. That doesn't need to be treated. In fact, in a lot of these situations where you've got more than one bacteria involved, treating one bacteria will help the immune system get on top of the other. So immediately that changed our choices, because as you can see, marbrafloxacin would be an appropriate choice for both the Pseudomonas and the E. coli. But we then also did one other final step, and that is talk about how the case was doing. Was the case already getting better? And interestingly, on chatting to Ronan, he was like, well, actually, yeah, I was going to take the drains out today. It's healing beautifully. It's 3 or 4 days later. The wounds look clean. if I hadn't got this result, I wouldn't even be thinking about changing anything. So based on that, we concluded that we don't change anything. We just finished the antibiotic course that he'd prescribed, which I think was 5 days of antibiotics. And we essentially concluded that the other parts of the treatment had helped the immune system resolve the infection. And I think that's one of the most important things that I always talk about in that, it's very easy to fall into the assumption that antibiotics replace the immune system. It doesn't. Antibiotics help the immune system control an infection that's overwhelmed the immune system. So essentially, the antibiotics suppress the infection to a point where the immune system can finish the job. Because when we look at why infections, when we're treating infections and why infections don't, will cause a problem in a patient, we've got a number of different areas we need to consider. Well, firstly, there's the bacterial factors, and that's going to be related to, the drug sensitivity. Have we got an antibiotic that will work? We've got virulence factors. Some bacteria are more virulent than others, so some are going to cause more aggressive infections. We've got the pharmacokinetics of the drugs. Will the drug that I want to use reach those target areas? If it doesn't, that's going to be a problem. So we might need to think about how we change our drug selection. And then, importantly, which I think often, it's very easy to forget about, there's really important host factors. So has the infection got a good blood supply? The infection site got a good blood supply so that the drugs and the immune system can get to the area? Is there necrosis? Is drainage required? But also, has the patient got a good nutritional status so that it's a functioning immune system? Without a functioning immune system, it's going to really struggle to resolve the infection, regardless of the antibiotics that you use. And in the case of the husky, essentially, the antibiotic Ronan had started, wasn't a good choice based on the sensitivity profile, so it may have not been playing a role. But he resected all the necrotic tissue. He established good drainage. The dog was eating well and it was otherwise fit and healthy. And it was those factors that predominantly helped this infection get better. So in this scenario, we elected not to use the culture results. Now, I'm not saying that culture results, you should ignore all of them. It's just be considered. You might not all, just because you've got the result doesn't mean you need to action on it. Site of infection is important. The site of the infection is going to influence your choices. Already, we've talked about the topical aspect. Breakpoints that are generated on the culture and sensitivity profiles are designed for systemic use for serum concentrations. So essentially, if you've got resistance on your culture and sensitivity profile, a topical product, if it's an option, may still work. So that's going to be most relevant for, skin disease, I would say. And if you can use topical products as well, that's obviously better from an antimicrobial resistance selection pressure, because you're only using it in the target area that you want to treat, rather than giving, as soon as you give a systemic drug, you may be approaching, you may be treating your infection, say in the ear or the leg, but you'll also be influencing bacteria in the gut, for example, as well. So topical, when you can, is best, but again, so for culture and sensitivities, the resistance and sensitivity profile won't be relevant. Site of infection is also important when you consider the pharmacokinetics of the drug. So some drugs are more lipophilic than others, meaning that they can penetrate into tissue areas more readily. And the main concern really from that point of view is whether you've got a barrier, a blood-brain barrier, for example, a blood-eye barrier or a blood-prostate barrier. And the drugs, were quite limited in the drugs that we use in companion animals, but there's three drugs really that are the most lipophilic. So fluoroquinolones, potentiated sulfonamides, and then the macrolides. So as much as it pains me to say, because obviously we want to avoid using fluoroquinolones, reduce their use. If you have a pyelonephritis, A fluoroquinolone is going to be a more appropriate choice, depending on your culture and sensitivity or your potentiated sulfonylureas, than amoxicillin clavinoic acid because it's, sorry, did I say pili? I meant prostatitis. If you've got a prostatitis, it's going to be more appropriate to use one of these drugs, because essentially once the infection starts to settle down and the blood prostate barrier starts to form, these drugs are still going to get in there and finish the job. Using non-lipophilic drugs, they're going to not enter as soon as the inflammation's settled, and then the infection's going to sit there and then resurge. The other thing to consider is side effects, and obviously with some drugs, you're going to avoid using them in certain patients. So, um, enrofloxacin, obviously in cats, where we've got our concern about retinal blindness, you're going to avoid using that, if that's one of the choices on your sensitivity profiles. Other examples would, if you've got a cat that's particularly difficult to pill and is going to be difficult to have water flushed into its throat after administering the pill, you're going to avoid using doxycycline because of the risk of esophagitis and esophageal strictures. And it's a little bit of a side note, but one of my things that I do talk about when I just do any talk about antibiotics is talk about how I feel. It's my belief that I think that antibiotics side effects are generally underreported and underappreciated in veterinary medicine. So we've got the classic drug reactions, we've got anaphylaxis, immune-mediated disease, we've got the retinal blindness, you've got the side effects to potentiated sulfonamides. All of those are well recognized and and vets are aware of them. But in human medicine, if you look at the records of an A&E department, for out-of-hour admissions, about 40% of those admissions and consults generally relate to medication side effects from medications that have been started that week. And usually about half of those relate to antibiotics. So it's really interesting that we don't really recognize those as well as much. And there might be species differences, but at the same time, my concern is that we tend to we tend to attribute that to the primary disease that we are actually treating. And there's a really nice study here that highlights that. So they had some very healthy kind of beagle dogs that they administered enrofloxacin and metronidazole to. And over a process of 2 weeks, 42% of the dogs stopped eating for a period of time. 80% of them experienced a vomiting episode, and 100% of them developed diarrhea. And antibiotic-induced diarrhea is well recognized in humans, but for a long time we didn't really recognize it. In fact, as we know, antibiotics were used quite commonly, and I guess what we don't know is whether the antibiotics are actually then causing diarrhea. But certainly, I can reflect on pretty ill cases that I've had hospitalized that have got subsequently gone on to develop diarrhea and vomiting. And actually, in retrospect, I should have been thinking about the drugs I was giving rather than just the primary disease I was treating. So of course, we've thought about, does the bug need treating? The site of infection is going to influence the kind of drug we use. We want to avoid side effects. But then we're also going to look at our bug, MIC, and breakpoint combination that we talked about in the first half of the talk. And then the final bit, really, in the decision making, is thinking about cost, compliance. Is it going to be practical? It's better that I use a drug that the patient can be given, than a drug that can't be. On that, there's some really interesting studies looking at. We're obviously going to be touching on a certain drug that's very convenient, but there's some nice studies in the States where they actually observed consultations, and a lot of the vets didn't actually ask owners whether they were comfortable trying to pill the cat. They just assumed, and as a consequence, they were then using a certain convenient drug a lot more than actually discussing pilling with the owner. And in a lot of situations, those in when they repeated the experiment again, they gave vets a standard kind of script to say, look, we could use this long-acting drug, but actually it's better for antibiotic stewardship if we use pills. most of the clients were very happy to try, and most of the clients were able to succeed. So, there's obviously, instructions you need to give owners. There's videos on the ISFM website to help them learn how to pill cats. But I just thought it was really interesting and worth noting that, as vets, we sometimes assume that owners don't want to try and pill their cat when in fact, and give them a long, might be tempted to give them a long-acting injection when in fact most owners are willing to try. So cost and compliance obviously come into it, and then prescribing tiers. So I don't know whether some of you are familiar with the prescribing tiers that are from these national organisations. So the WHO has a veterinary classification to try and classify different drugs of high priority, critically important antibiotics, critically important, highly important, important. It's not the clearest of guidelines. Even as an antibiotic geek, I find it a little bit confusing because it's based on licensing and it's designed for the whole world and drug availability. So one of the systems I tend to use more is the EMA, European Medical Agency grading system, where we have drugs grouped A, B, C, and D. So the drugs in group A we really shouldn't be using in veterinary species. In fact, it's illegal on mainland Europe to use any of these drugs. So that's like carbapenems or linosinide. Group B includes third generation cephalosporins and fluoroquinolones. So these are drugs that you shouldn't be using unless it's only the culture says that you need to use them, or you've got a very specific pharmacokinetic reason. In fact, on mainland Europe, in most countries now, you're not allowed to use these drugs without a culture and sensitivity to prove you need to use them. And then we've got group C, so that's drugs like cephalexin, amoxiclav, and then group D with the tetracyclines and amoxicillin. So the idea is that the group D is used first, and then you move to group C and then B. So when you look at your sensitivity profile, if you've got three or four, three drugs that you could use based on suitable pharmacokinetics, etc., you want to use a drug that's lower tier, which is optimal for antibiotic stewardship. So I'm just going to finish now with another quick case, and essentially, if you want, you can play along and think about the decision that you would also make, but I'm conscious I don't want to go over time. So this is, well, it's the same culture and sensitivity profile that I've brought up throughout some parts of the talk. So we've got lots of S's, as you can see. We've got all these drugs down this side, and we've got our breakpoints. And this is an American profile, so there's going to be some drugs on here that you're not going to be as familiar with, like cefodoxime, but just think about the drugs that you are familiar with and use in your practice. So this sensitivity profile was taken from a urine sample, and it was part of a monitoring kind of profile for for an endocrinopathy. There was no clinical signs exhibited in this patient, and if the only thing to note was the culture profile yielded up this E. coli, and there was a few white blood cells in the urine. So what are the antibiotic choices that we make in this case? Well, hopefully, based on what we've talked about today, we'd consider, yes, this is an E. coli and it could be causing infection, but we've got a patient with no clinical signs. So this is most likely representing asymptomatic bacteria, so we don't need to prescribe an antibiotic, we can just monitor. If we change the clinical presentation, we're using the same culture profile, but we're just slightly changing the history, and that influences how we approach this sensitivity profile. So sample taken by cysto, so we think it's reliable culture, it's not a contaminant, but now the dog has signs consistent with lower urinary tract disease, so stranguria, plaquuria, and there is pyuria. So we're diagnosing a cystitis. So in that situation, we're probably going to use amoxicillin, and that's because we know that it's concentrated in the urine, and we're comfortable that it's sensitive, but then also it's a lower tier antibiotics. It's at it's the lowest tier that we can use. Same culture and sensitivity profile. However, we're changing the clinical history. So this time it's a Labrador where we're taking the sample by cysto, but this dog's got renal pain, it's got polydipsia, it's got unilateral renal pelvic dilation and ultrasound, and there's white blood cells in the urine. And pyelonephritis is possibly overdiagnosed. It's very difficult to definitively diagnose, but in this case, we've got, a pretty convincing, clinical presentation. So I think we can be quite confident this dog has pyelonephritis. So now we go back to our sensitivity profile and we think, okay, well, we've got a range of drugs that could be appropriate. We've decided that we definitely need to treat this dog. However, because we're treating a renal, a pyelonephritis, we're not going to be using a drug that's going to be concentrated in the urine, like amoxicillin. And if you remember, we've got, we want a drug that's going to be more lipophilic in this situation. So that's why, even though we've got a number of different options, we need to pick a lipophilic option, and it's going to be a fluoroquinolone. So either enrofloxacin, marbofloxacin, or potentially one of the other drugs that is lipophilic is potentiated sulfonamides. So I hope that example just shows how, the same result can be adjusted based on different factors relevant to the pharmacokinetics, but also the clinical presentation. And then my final request on the final slide is a quick favor. Jade's circulated it round, I think, on your hub, and it's in the chat. I'm involved in a survey of standard kind of perioperative prescribing protocols by veterinary surgeons, both in the US, Europe, and the UK. It contains a variety, the survey takes around 10 minutes max, but it contains a variety of different surgeries ranging from spay, splenectomy, gastrotomy, T-pillows, laminectomies. And we're not expecting everybody who fills in the survey to be able to do, say that they do all of the surgeries. In fact, when you go onto the survey, you select the ops that you routinely do, and then you only answer the questions for those procedures. We're trying to get as many people on board as possible, hopefully so that we can compare UK prescribing with prescribing on mainline Europe, but then also with the USA, and see what areas that we can have for opportunities for learning. And with that, I shall finish.
I've obviously got questions, but I like to let other people see if they've got some before I start teaming.
Oh, sorry, I just kind of lost my train of thought on one of the slides with the fluoroquinolone
No,
breakpoints.
no, no. Does anyone else want to ask questions? Put your camera on and join me and Ian. You don't have to. There's Libby. Here she comes.
Always got questions, haven't I?
Well, I
Sorry,
do too.
probably a bit
Otherwise,
stupid.
go for it, Libby.
Hi, Ian. Thanks very much. Nice to see you.
Mm.
Um, you were talking there about kind of really, really interestingly about how the antibiotics kind of aren't doing the job. They're almost like dampening things, knocking things out, so the immune system actually then clears the infection rather than the antibiotics, which is such a
Yeah.
different way of thinking about it. I've never thought about it that way before. But putting on my nutrition hat, do you think there's any role then for probiotics in terms of, helping support the immune system, even boosting the immune system in terms of infections? And I know kind of we think about antibiotics with probiotics alongside just to help to kind of support the microflora. But do you think there's any role
Oh,
for it? I know we probably couldn't measure it, but
that's a PhD. But I guess I mean there's a lot of excitement about the microbiome. And I'm fully behind it. I'm not skeptical about it. But I guess for me, I think there's also a lot of things we don't fully understand about the microbiome. Certainly, it interacts with the immune system. There's really interesting studies in humans where children that are, I think, less than 1 year old, if they receive antibiotic courses, their risk of asthma increases. So there's obviously, an influence of the microbiome in those situations on the immune system learning. How we can use probiotics to navigate some of the issues we've got. It's oh, let's some of the I'm trying to think about how to cover lots of different angles in keep it succinct. I guess one of the challenges with the probiotics is that some of the formulas have been, that were available in veterinary have been cultured from human um, strains of bacteria or bacteria that have been found in humans. So we don't know how well they perform. There's billions of bacteria in the microbiome, and I'm often a little bit concerned that if we send like one or two random bacteria into the gut to try and sort everything out, that seems quite a big job. Sending like one or two soldiers in to kind of change a whole war. Um, but from my point of view, the less we can use antibiotics, obviously that's going to be better from a microbiome point of view, disturbing, but also nutrition. If you think about, the influence of nutrition on your microbiome is going to be huge. So the sooner you can maintain, a normal diet for that patient, when you've got a really ill patient, we know about the importance of having feeding tubes in, making sure that they eat to heal. Well, eat to heal not only supports the healing process, but it also eat to maintain your immune system. So that's really important as well. So I've probably waffled around a little bit because it's quite a big, all-encompassing question. But
Yeah, no,
that,
I know. I appreciate that. Yeah. And I'm probably, like you say, kind of the food and things like prebiotics in the food can help support the bacteria and so forth,
yeah.
which then talk to the immune system. So, yeah, it's all kind of interacting with each other. Yeah, that's great. Thank you.
Anyone else got any questions?
Well, could I ask a question? Did the breakpoint bit, did the bit at the beginning make sense about the breakpoints and how they're generated and
Yeah.
and
Yeah.
how they're going to change? I mean, it'd be really interesting if you guys all phoned your labs and found out whether they are updating their breakpoints.
I'm obviously going to do
Oh, I know you will.
it. Yeah, no, I will. I'll check that before we speak again at the next our next CPD. But can I ask a question about the whole ear thing has got me very interested because like obviously every single one is marketed ear swab culture. Like it's a
Mhm.
specific thing on every, lab test that you can do. And essentially, unless you're looking for Pseudomonas, there isn't any point.
Yes,
You can just do microscopy in-house and just look for rods and cocci.
yeah, and the only reason you're looking for a Pseudomonas is if you're worried, if you're worried you might have to be getting biofilms and stuff like that. But the sensitive, I mean, you could send it to the lab and they can identify it for you. That's fine. But the breakpoints are all based on blood levels of the drug. So, if you can, resistance isn't like the drug definitely won't work. It's just at that concentration, the drug won't work. So if you can reach 20, 30 times concentration topically, or
Which
even
you wouldn't
100,
be doing. Yeah.
it could overwhelm the resistance mechanism. So that's why all the really interesting work with the ears, where people are actually just focusing on using, changing the ear canal form, reducing the inflammation, opening up the ear. That's, in Scandinavia, they've been doing it a little while now, where an otitis externa that's really sore and really difficult to manage, they'll just treat with steroids initially and an ear cleaner, and a lot of them will resolve. I guess it's only if you start getting into like otitis media, that's when you're going to
Mhm.
need a culture and sensitivity because you're going to have to use systemics. But in a lot of situations, you know, if it says it's resistant on the sensitivity profile and you're using topical, who knows?
Okay. Thank you. I mean, I know with Sue, when we talk about our antibiotic stewardship, she's a massive, advocate for, yeah, steroids and not really doing much else, So, okay. And then the other thing I was going to ask, because we had that one that you were talking about, the pyelonephritis. So,
Mhm.
how do you gauge how long you would treat that for with antibiotics?
Oh, that's a that's a juicy one.
Because
Um,
I know I've gone to one of your talks before, and no, it wasn't, you were in the panel and people were talking about CRPs. And is that a useful thing to, monitor? It was more with, sorry, pneumonia, I think, with that one.
yeah,
So
yeah,
you
yeah.
weren't having to do repeat chest x-ray. and if you
Yeah.
want to know when you should finish your course, in theory, you could use a CRP. And I remember your answer on that, but I was just,
Was I
I was
skeptical? I don't
just
know.
wondering, because from a pyelonephritis point of view, obviously, yeah, would you just do repeat urines,
Well, yeah.
or
Well, well, there's two bits there. I can't remember what I said because it was at BSABA, wasn't it? So it was a while ago. So I might be more cynical now than I
you
was.
were fairly cynical then.
Was I? So, well, just for the rest of the people who are on, we're increasing our knowledge and understanding of using acute phase proteins in those situations for monitoring. However, if you've got a bad pneumonia and you treat it and you get rid of the bacterial infection, the body's still got to heal. You're still going to have inflammation there. So you might be treating longer if you're monitoring the CRP. So I guess it's we don't know, but I certainly don't. If I don't, I didn't start using them. I went off clinical signs and a combination of experience, I guess, because I know some people who've been following CRP who've increased the length of their courses based on their CRP, and you're like, well, maybe the infection's gone and it's just healing. Inflammation causes CRP elevation. So that's the first bit. Pyelonephritis, really tricky. If you look at veterinary textbooks, traditionally, they'll say 3 to 4 weeks, and that's based on historical recommendations from humans. That if you look back at where those recommendations were from humans, they were just picked out the air, and they were just a convenient number of, most of the courses, if you look historically, are multiples of 5 or 7 or months because they're convenient times to remember. Why would a bacteria recognize, if the Babylonians who created the calendar had said a day a week was 3 days rather than 7 days, we'd all be treating in multiples of three. So, that's where that's all come from. Now, what's really interesting is in the human sector, they'll quite commonly only treat pyelonephritis for a week. Um, so, it's a lot shorter duration than what we will. We don't have that. We're never going to be able to get the studies to look at that because it's really hard to diagnose pyelonephritis accurately in dogs and cats, in my opinion. I think it's overdiagnosed sometimes. But certainly I wouldn't be treating for 3 or 4 weeks. I would be probably treating for a week, reassess, maybe a little bit longer. As long as you're choosing a drug that will reach the place
Right,
that you are treating.
and how do doctors decide? I mean, so you were saying about kids under one. Like, I can't tell you how many antibiotics have tried to be prescribed to my son,
Yeah.
that I've said categorically I'm not giving, but they give me them home anyway. Um, but
Yeah.
what's their, what kind of prescribing are they having to follow? If you're saying in like mainland Europe, they have to do a culture before they can prescribe certain things. I still personally am finding that my doctors are giving out antibiotics very
Oh, yeah.
easily.
So, sorry, I should have said, the fluoroquinolone third generation cephalosporins, you have to have a culture that's for vets. So
Okay.
vets aren't allowed to prescribe those drugs. In Holland, they're allowed to prescribe it for prostatitis and sepsis. For those emergency situations, they're considering bringing it area wide. Um, but it's the doctors have got nice guidelines that they follow. But even though there's nice guidelines, they're a guide, and ultimately, when you look at veterinary practice or you look at human practice, there are people who follow the guidelines, and then there's always the people with much lower prescribing thresholds. So there's studies by the CDC, and I think we can this is for America, but we can translate it to the UK and other places where they looked at the prescribing in multiple hospitals, and I think it was 10% of the doctors accounted for 45-50% of the prescribing of antibiotics. They are high prescribers.
Mm.
So there are people who just have much lower thresholds, and I guess what the check, there's people who are more comfortable adopting it. There are some people who aren't, and I guess now what they're recognizing is it's more useful to target that 10% because you'll have a much bigger impact in reducing. But again, the doctors have guidelines, but whether they follow it,
Yeah, yeah. I mean, I guess it's because I know they obviously have these guidelines, but I
yeah,
just would have thought like I don't know, he got scratched by a cat and like a 7 day course. And I was thinking, really, does he need a 7 day course? But I
Yeah.
was like, they must have guidelines like that say for
Yeah.
this, use this many days and stuff. So it was just interesting. And
Yeah.
obviously, every time he goes in with a wheeze, they want to give him
Yeah.
antibiotics. But
No, with my stewardship role that I've just done, I very quickly just realized, because there were the same issues in all the countries I was working with. Stewardship's actually a behavioral science issue because
mm,
there's lots of different drivers. There's defensive medicine, there's worry about things going wrong. There might be a case that went wrong once and they
mm,
only complained and you weren't supported. Then you think, well, that's never going to happen. So, there's to changing behavior of prescribing antibiotics to align with guidelines, there's individual factors, there's environmental factors. In fact, environmental factors are one of the strongest things, whether you've got a supportive environment and you know that you're not, the amount of times I've had young vets come up to me and said, I didn't prescribe antibiotics, and then my boss did. That sounds
mm.
very familiar, doesn't it? So there's lots of different factors involved, and they also are replicated in the human sector as well.
And do you find like the things that they started where you could give out a prescription that says, I'm not prescribing antibiotics because, has that helped? Like we don't use them, but I know that I've heard of them being used. I don't know if
Um,
that had a
so
big uptake when that was introduced or not.
I know that they're popular, certainly from practices that have been using them who wanted to really push not giving antibiotics. They were all based on evidence in the human sector. There's been a number of countries that have introduced them. They call them delayed prescribing pads, and they're very effective because you know the when we designed the BSAVA ones as well, we put the you have to write in it because it then feels very individual to the
Yeah.
patient. If you walk into the doctors, they grab a standard leaflet and just thrust it at you. You don't feel like they've really listened and it's part of you. So that's why we made it that you have to fill the
Yeah.
individual in and things like that. But yeah, they're certainly effective in human medicine. In I think Australia, they've been used quite a lot and really driven down antibiotic use in some practices because people feel like they just need to give people something.
Mm. Okay, I'll stop asking
I
questions.
don't know, they're good questions. We've kind of gone away from, we haven't really talked about AST, have we? We've kind of moved into other aspects. So hopefully all relevant and useful.
Mm. Um, yeah, fecal cultures, but that's a totally different talk. So
Well, we
I might
can
have to have you
touch
back
on
on
that.
that one.
Yeah, yeah. Or we can touch on that at the next session when we just, if everybody goes, oh, the policies are all great, we can say, oh, fecal
I
cultures.
hope so.
Then we can just freestyle it.
Okay. Anyone else? Because I'm aware we're over time. Because I asked too many questions. Any more for any more?
Hi, Libby knows me. Um, I'm not a vet. I signed, just followed the link, clicked in, completely lost from slide one. But
Well,
thank
thanks
you
for staying on.
all the same. There weren't many people on the call, so I just thought it's a bit rude just to drop off after 2 minutes. So I've kind of been listening, but it's not a clue what you're on about. But thank you all the same.
Well,
Well,
thank you.
welcome to my club, Matt. Thank you for joining me in my club of not knowing what's
Uh,
going on.
I've been signing up to my own sort of CPD in the background for stuff that I actually understand. But thank you.
Oh, thank you. Well, yeah, thanks for keeping the numbers up.
That's me, isn't
All right. Well, thank you, Ian, as always. Thank you for everyone who came. And yeah, it will get put onto the volunteer portal for people to watch back for their CPD in future. And Ian will be back to do a Q&A on our new SOP or antibiotic use in street vet backpacks, and hopefully we'll release it so you guys can have a read of it and come in with any questions that you guys have got and just general discussion. We're open to chat about it and see what you guys think and what feelings you've got since you guys are using the backpack in situ and might have some strong opinions or thoughts on it. So without further ado, 9:10, go and enjoy the rest of your evening. And thank you so much, Ian, as always.
All
See
right.
you in Feb.
Take care.
Thanks, guys.
it?
Bye-bye.
So yeah.
Bye.